Antitussive Dextromethorphan and Expectorant Guaifenesin are common combination in over-the-counter medications. For instance, bilayer tablets of Mucinex have these two drugs. This drug combination is also sold as Robitussin. Let's look at dextromethorphan first, okay? It's the third and final antitussive in the list. Dextromethorphan is a most commonly used over-the-counter cough suppressant. It is a centrally acting non-narcotic agent. This drug suppresses the cough reflex by a direct action on the cough center in the middle of the brain. It is a structural analog of morphine and codeine indicated for cough. Let's look at how this drug works. Unlike codeine, this drug binds on sigma opioid receptors. Remember, codeine was binding on mu opioid receptors, right? Although structurally similar, since it binds on sigma opioid receptors, dextromethorphan therefore does not have a classic central nervous system effect like other opioid agonists. Less effective than codeine, but of course with a less adverse effects and side effects. Its major mechanism is by blocking NMDA receptors of the brain's respiratory center, inhibits neuronal depolarization, thus blocks cough reflex. Remember, NMDA receptor is a glutamate-mediated cation channel. Dextromethorphan can take over the binding site of glutamate neurotransmitter non-competitively on NMDA receptor. In addition to cough suppression, this drug can inhibit glutamate's excitotoxicity and promotes neuroplasticity, all because of this receptor binding ability. Glutamate is the most abundant excitatory neurotransmitters in our brain. Therefore, this drug's many actions and adverse effects are associated with this mechanism, particularly about that NMDA antagonism. Since this drug can block glutamate receptors, it influences many other neurotransmitters and neuronal circuits. You don't have to remember all these detailed mechanisms, but two things to remember because it is important for drug interactions with the MOA inhibitors. Dextromethorphan can block serotonin and norepinephrine transporters, thus increase these neurotransmitters in the brain. Also, this can boost up dopamine in the brain. This is an FDA, there is one FDA approved drug combination with bupropion for major depressive disorders. By inhibiting serotonin reuptake, dextromethorphan can increase the serotonin level in the synapse. You don't have to memorize all the details, but just remember the serotonin's role. Because if anyone do overdose or misuse cough medications with the dextromethorphan, these mechanisms are related for the hallucinations and euphoria. Okay. Let's look at the pharmacokinetics. This drug is metabolized by the liver. This has a very low bioavailability due to extensive first-pass metabolism. Keep in mind, dextromethorphan is a centrally acting drug, need to pass the blood-brain barrier in order to achieve the desired pharmacological effect. As soon as this drug gets into the liver, it undergoes quick metabolism. I don't want you to worry about this big chart, but just remember these two first steps. That's very important, okay? So what happened is, by demethylation, this dextromethorphan gives an active metabolite called dextrorphan. This metabolite can pass blood-brain barrier. It has a significant pharmacological activity, particularly at NMDA receptors like the dextromethorphan. But there is a problem. As soon as this metabolite formed, it quickly converted into glucuronide. This metabolite, dextrorphan or glucuronide, has permanent charge in this and therefore less permeable to blood-brain barrier than unconjugated dextrorphan. Therefore, this glucurinated metabolite cannot produce significant pharmacological effect in the brain. Glucurinated compound usually are rapidly eliminated by the kidneys. So that means this drug metabolized and eliminated very quick, even though a relatively minor CYP3A4 pathway exists, CYP2D6 is the primary enzyme involved in dextromethorphan metabolism. Many patients have this enzyme polymorphism also, as you already know that. Dextromethorphan rapidly metabolized in liver by this CYP2D6 to the active metabolite dextrorphan. This is the reason quinidine is added to dextromethorphan to treat bulbar effect, okay? Because of its rapid first pass metabolism and the existence of enzyme polymorphism, often when dextromethorphan is given, it lacks therapeutic response, okay? If you forget everything from this slide, just remember this story, okay? So that's the important part, because dextrorphan can pass blood-brain barrier, and the conjugated glucuronide form cannot pass blood-brain barrier, and the CYP enzyme CYP2D6 is the major metabolite responsible for this metabolism, okay? In summary, if I summarize, metabolite dextrorphan is a pharmacologically active component, also responsible for this drug's neurological side effects. Further, glucurinated to form dextrorphan or glucuronide, the most prevalent form of drug present in the plasma, about 98%. Because of it, it is charged metabolite. It is unable to cross the blood-brain barrier. Its half-life is about 4 hours, and metabolites are rapidly eliminated by kidneys. One more point, for the metabolism of this drug, you need liver enzymes, and for the elimination of this drug, you need kidneys. Therefore, patients with a hepatic and renal impairment, there should be a variation in the drug concentration, okay? Then the last section, the adverse effects. Generally well-tolerated drug. GI discomfort is common in patients, especially diarrhea, and in some patients constipation and stomach pain. But if you compare with codeine, this has very mild adverse effects, especially if it is a short term and a low dose. But if long term and abuse or overdose can cause GI discomfort. What is the reason? Even though dextromethorphan and codeine are related structurally, dextromethorphan can only bind on sigma opioid receptors, but codeine binding on mu opioid receptor. Keep in mind, GI nerve plexus has mu opioid receptors a lot. That is the reason codeine give more constipation, okay? Just to distinguish. Anyway, the patients often reported to have a drunk feeling or feeling high, often with hallucinations. Dissociative effects similar to PCP drug abuse. Dizziness and sedation are also common with a high dose. Dextro drug abuse is called robotripping, often in teenagers. It's an overdose. High doses can cause euphoria. That is because of the interaction with all these neurotransmitters, glutamate, dopamine, serotonin, norepinephrine, acetylcholine, all these, right? That is not good for their brain. The reason, remember, glutamate is the most numerous excitatory neurotransmitter. So if you mess up that, it's going to, you don't want to mess up your brain. Better be very careful. It's your brain. If you don't take care of it, nobody going to take care of it, Anyway, back to the drug. Its abuse potential is due to NMDA receptor antagonism. Overdose can cause neurological and cardiovascular toxicity. Neurological adverse effect also related to this mechanism, okay? So this drug is contraindicated in MOA inhibitors. Dextromethorphan should not be taken with a monoamine oxidase inhibitors due to the risk of serotonin syndrome. Dextromethorphan and its metabolites could increase brain serotonin concentration via serotonin reuptake inhibition. Many antidepressant drugs work by blocking the same receptors. Therefore, adding dextromethorphan rapidly enhances the action of these drugs. Okay, so in dextromethorphan, you need to learn the indication. It is for the cough. Then mechanism how these drugs work, major by in blocking the or inhibiting the NMDA receptor, that is the glutamate neurotransmitter related one. Then drug interaction, it is related to serotonin receptor reuptake function, but mechanism of action related to the drugs pharmacokinetics. So you need to learn that CYP enzyme, CYP2D6, that is important, and also this general adverse effects, because if a patient takes overdose or abusing that. And the next topic will be expectorant, guaifenesin, and mucolytics. Okay, hope this helps.